Thank you everyone for joining us this afternoon and adding a session to your lunch hour. We have Dr. Christopher Reilly with us this morning, and I'm just going to read a little bit about him. I won't do nearly as good of a job as Dr. Selby would have done yesterday, but Dr. Chris Reilly is the head of the Department of Orthopaedic Surgery at BC Children's Hospital and the head of the Division of Pediatric Orthopaedics at British Columbia University. He completed his fellowship in pediatric orthopedics at the Texas Scottish Rite Hospital in Dallas before joining the orthopedic group at Children's. He is a pediatric surgeon specializing in the management of pediatric trauma and spinal deformity. He's also a pediatric consultant at the Neuromuscular Clinic. And I will turn it over to Chris. I just wanted to remind everyone, please do put your questions in the Q&A section at the bottom of your Zoom screen, or you also have the opportunity to put questions and answers into the Q&A section on Whova, and we'll be able to monitor that throughout the presentation. So Dr. Reilly, over to you.
Well, thank you very much. The first thing I need to do is apologize to Wendy and all the organizers for my timing. I totally messed that up after a long week, and I got my day wrong. So I'm sorry to all the organizers and all the participants. And I really appreciate actually anybody taking the time out of your lunch hour to be part of this session. And what I'd really like to do and would enjoy the most is answering people's questions. I thought I would discuss a couple of key points. I don't even think I need slides. I have some strong opinions, as some people will know, about bone health and musculoskeletal health. So I just want to touch on a couple of points, and then maybe hopefully people have questions that I can answer, because I think that's the best way we could maybe spend our time together in this weird format of virtual health. And the first thing I wanted to do, or outline of my perspective on bone health, is let everybody know a couple of laws that are important in kind of orthopedic care. We think of bones as very static structures, but there's a thing called Wolff's Law that really states that bones respond to the mechanical environment they're in. So for all of us, our bones are kind of living structures that are constantly being updated and changed, and they're changed in response to how we all use them. So for any of us, keeping our bones healthy means using them, and our bones can detect that use. There's some special little sensors on bone cells that actually measure mechanical load, so that the best way to strengthen your bones is to use them. And in children, that principle is even greater because of growth plates, and it's expressed in a thing called the Hutter-Volkmann principle that was described long ago, and really tells us that growth plates respond to their mechanical environment, and there can be an optimum mechanical environment for growth plates where they get loaded, and there can also be suboptimal mechanical environments for growth plates. Either overload or too little load can result in the growth plate not functioning properly and abnormalities in growth. And that Hutter-Volkmann principle is important because it applies to growth plate cartilage, but also the cartilage that is in our joints. So for joint health, so you keep your joints healthy by using them with an appropriate amount of load and an appropriate amount of frequency. So if we grow cartilage cells or growth plate cells in a petri dish in the lab, and we put pressure on them of the right amount and the right frequency, they actually do the best. So you can keep your joints healthy by using them, and also you can influence growth of children's skeleton and joints through use, so that the appropriate amount of load creates healthy joints that are shaped properly, that will be functional in the future. And we do see that children with muscle diseases have trouble with growth. So children with disorders such as spinal muscular atrophy have a very high incidence of hip dysplasia, because their hip is actually not growing properly, because the muscle forces across the hip are not stimulating the appropriate growth in that growth cartilage. And we see in patients with Duchenne's muscular dystrophy a very high incidence of scoliosis, for example, in part related to that difference in growth. So that's one of the key features that we use in treating and assessing patients in the clinic to try and ensure the best health. Is one of the things we want to do is maintain their motion and maintain their joint loading so that their skeleton develops in the healthiest way possible. It's a complex issue, however, because that has to be done while really protecting muscle membrane integrity. So the lining or the membrane of the muscle cells, it can be damaged, and we want to maintain motion and muscle function without adding to the stress on those muscles. So I'm a huge fan of a couple of principles. One would be consistency for all our patients. So doing a certain amount of activity each day, even in holidays or times off, and also using activities that involve motion without undue stress or the right amount of stress. So swimming is a great example. Walking and swimming are great activities for the health of your hips and your spine and your skeletal development as a whole. So children involved in those activities, I think that's a really positive thing. And I'm a huge fan of pool activities or pool-based activities. There's many people who I interact with in the clinic probably already know. It branches into another principle, and that is that the link between muscle growth and skeletal growth is disrupted in patients that have certain neuromuscular disorders and muscular dystrophy in particular, so that bones are smart, they know how to grow, they're programmed in by genetics, but muscles don't, and they rely on stretch to grow properly. And if that signal is interrupted, as it is in muscular dystrophy, we need more stretch to stimulate muscle growth, or we see contractures develop, especially in what we call diarthrodial muscles, or muscles that cross two joints, like the gastroc muscle. So we see the foot deformities, or the hamstring muscles that cross the knee and the hip. Those muscles tend to get very tight. So in many children, we want to try and increase the signal for those muscles to grow through static splinting. And the advantage of that is that it maintains the muscle in a optimum position, for example, during sleep. It's not aggressive. It's not dynamically stretching the muscles, which we usually want to avoid. That tends to not work very well. But we do want to statically stretch those muscles with splinting. And that leads to kind of a gentle, easy stretch. And whenever we're doing stretching, we want to avoid any kind of aggressive stretching. I really want to comment on, just in my last couple of minutes, two surgical areas that are important. And one is spine surgery, which is the main reason that I guess I was brought back to Children's Hospital originally. Was there were many patients that were needing spine surgery who had different muscle diseases, and that used to be a major part of my practice. And nobody really wants to have a spine surgery. It's a huge issue, and we're doing everything to help patients avoid that surgery if they can. And Dr. Selby, happily, many people will know, is actively putting me out of business. The incredible therapies that she's utilizing and are being developed by incredible researchers around the world, in Canada and around the world, are putting me on the sideline frequently, which is excellent. And one example would be our use of deflazacort, which has incredibly changed the need for spine surgery. When I reviewed 50 of our patients prior to Dr. Selby using deflazacort and then 50 afterwards, only one patient in the after group needed spine surgery, and they were actually not getting deflazacort every day. They were getting it on a periodic basis. So prior to that, 95% of my patients would need spine surgery. And after that, a very small percentage would ever need spine surgery. So that's really been an incredible advance. And those kind of advances continue. The other area I wanted to specify was the potential need for foot surgery. And this is an area where I think we're probably being a little more aggressive and trying to ensure that we do everything we can to protect our patients' foot structure and ability of their foot to bear weight and to have good range of motion. And the incredible results of again, the therapies that are being used really demands that. So we're really, if in any area, being more aggressive. It's sometimes being more aggressive about recommendations around orthotic use and potential surgery to try and maintain range of motion and function for our patients. And I think really those are, I've taken about 10 minutes, so I'm pretty close, maybe 12 minutes. So I think those are really the key points as an orthopedic surgeon that I want to stress. And they really generalize to all conditions that I treat, the bone and joint health through all neuromuscular conditions, but especially patients with Duchenne's muscular dystrophy. Those issues are really critical. And I'd love to, Wendy, to answer any questions that any people on the call might have.
Perfect. Thank you, Dr. Reilly. So far, we just have one question right now, and it is, how do you decide when and if scoliosis surgery is necessary?
Okay, well, that's a great question. I've only got one, but it's a great one. It is a complex decision proceeding with scoliosis surgery. And if we distill it down to kind of two issues, it would be the magnitude of the deformity and the age of the patient are really the critical issues in deciding how significant the scoliosis problem is going to be. So young patients have the opportunity to increase their curve magnitude over time. So that's always a risk factor. So the same size curve in a young patient is much more of a risk to that patient than it is in an older patient. And curve magnitude is a issue because the larger curves lead to greater dysfunction. Spinal deformity can lead to difficulties with seating or walking or standing, and also organ function. Heart and lung function can be affected by changes in the shape of the chest. So those are the main issues. But usually it involves a pretty detailed discussion with the patient and family. And I find that usually everyone as a result of that discussion kind of comes to the same conclusion, because they're living often with a significant deformity. And usually when I am worried about the deformity being a problem from an organ perspective, that the scoliosis is going to hurt somebody's breathing or heart function, they're starting to realize the significance of it just because of the structural nature of that curve. The number that gets thrown around for that organ or lung function issue is kind of in a degree is 50 to 60 degrees in that kind of range, but that's very, very variable depending again on the patient's age and the location of the curve and the overall structure of the curve.
Perfect, thank you. We do have a number of other questions that are coming in. We do have a participant that just raised their hand, and I actually just unmuted you. So I'm just going to ask if you
great.
can unmute yourself, and maybe we can hear you live, if you don't mind, Brad.
Hi, it's Brad, and yes, I typed my question as well, but it was basically, what is your opinion on zoledronate therapy in patients with mild Duchenne or Becker's, and what's your thought about cost versus benefit, like the cost of the stress of patient actually going through the procedure versus sort of the long-term, short-term and long-term benefit?
Okay, thanks for your question, Brad. I think many of my patients get zoledronic acid therapy, and it is across patients of many different ages. And it relates to our really aggressive use of steroids, and in particular deflazacort, because there's a negative effect of deflazacort specifically on vertebral bone. So the cancellous spongy bone that makes up your vertebral structure is affected significantly by the steroids that are helping muscle function. So those steroids can lead to a decrease in the strength of that bone. And in some patients, we see compression changes in the vertebra, which we want to avoid because it can lead to a deformity called kyphosis. It also leads to pain and could put that patient at future risk of vertebral fractures or deformities. So many of my patients are taking zoledronic acid therapy, and my experience with them is that although often the first time they have that treatment, it can be associated with a lousy experience and feeling sick. The subsequent visits are way better than our old therapy with pamidronate, and usually it's tolerated very well. It is a complex medication that's actually incorporated in bone. So experts like Dr. Metzger, who spoke yesterday, are really important to listen to about the long-term effects of that medication. But I see dramatic improvement in my patients' pain and in preventing future deformity in their spines because of the effects of the disease and the steroid treatment on that spongy bone. But I think it's important that it's combined with other therapies like vitamin D, especially in Canada. It's dark and gray here today in Vancouver, so we spend 6 months in the gray, so vitamin D is of critical importance. And the activity that I talked about, one of the reasons I'm always discussing that with my patients is for their overall bone health. So whenever you're up and mobile, you can be thinking, my receptors on my cartilage cells and my bone cells are feeling this activity, and they're going to strengthen those bones. So the combination of motion, activity, adequate vitamin D, a good diet with protein intake is really where you want to start. And then occasionally, and many of my patients who are on steroids, the zoledronic acid is a great help, in particular for the spine issue.
Perfect. And Brad actually had a follow-up question to that one, Dr. Reilly, is any possibility of an oral version in development?
Well, there are many oral bisphosphonates, especially used in adults. So it's a common medication in the elderly who have osteoporosis. So it's used quite frequently. There's some differences in younger patients. So usually we're using the IV medication. I'm not the best person to ask if there may be an oral formulation like zoledronic acid. I do know that for our we've been waiting for an effective oral medication that didn't have the dysphagia and other side effects that was equally effective, but we're still waiting for that for pediatric patients.
Perfect, thank you. And a little bit of a comment, but 2 comments about AFOs. So we have, it's really important for the boys to consistently wear their AFOs over time, and Reilly's trying.
That's good.
And then
good.
the other question here is, our current team suggests daytime walking AFO use instead of nighttime. This is different than what we have always been taught. Is nighttime AFO use still the best practice?
Well, that is really depends on the patient in particular. Daytime AFO use can have some negative effects depending on the patient's strength and mobility and how they're moving. They can be heavy to wear. So in many of our patients that don't need daytime AFOs, we elect to use the AFOs at night. If there are other reasons for using them during the day, and there's some benefits to that, then sometimes we will elect to wear them during the day. But in our practice, as we're starting the AFOs as a tool to help with tendon growth, we usually would start with nighttime wear, and allow that patient to have the full range of motion during the day, because that also stretches those tendons. We want that joint to move during the day and for those tendons to be stretched. And in a way, you know what, if there's a little bit of muscle inflammation, you're going to bed at night and you fall asleep and your foot is all the way down, and if you look at a child sleeping, often their foot is all the way down. When they get up in the morning, there may be even some edema in the muscle, and it's hard to get that range of motion back. And if your tibia's grown overnight, you've lost a little bit of motion. And I think I've noticed in our patients that can wear the AFOs on a regular basis, especially starting from a young age, it has really great benefits. And they do put me out of business in terms of needing to do tendon lengthening surgery, because their tendon grows, they don't get the contractures, and it's far easier to prevent the contractures from developing than it is to try and recover it later. We really want to get on top of it and prevent them from developing. So I hope that's answered that question. But as our go-to initially, especially in younger children, nighttime is initially the way to go.
Perfect. And speaking of AFOs, somebody else just posted a question here. We should have a couple more to get through before the next 7 or 8 minutes here. But somebody said AFOs are still a very hard sell at their house. Do you have any tips on how to motivate a team?
Yes, they are a hard sell, and I've been here since 1996, and it hasn't gotten any easier. They're lousy. They get caught up in the sheets. It's one more thing to do, and maybe I have understand a tiny perspective, because when I'm doing spine surgeries, I clench my jaw when I'm under tension, and I crushed one of my teeth and killed it, and then I get this jaw pain. So after a 10-hour surgery or something, I'll go home that night and my jaw will be sore. And then at night before the surgery, I'll clench my jaw. So of course, like many people maybe in the audience, I was prescribed a splint to wear at night, and I hated it, the mouth guard, and I didn't wear it. And finally, the situation got desperate. I was going to lose another tooth, and I forced myself to do it. And now I don't even notice it so much. And so it's the first thing I do. So I think the families that I think have been most successful, I've learned from them, and they approach it in just a consistent approach, kind of like brushing your teeth. They have a routine. They stick to the routine every day, and it's part of life. You don't go to school naked without clothes on. You don't go to bed without brushing your teeth, and you don't go to bed without wearing your AFOs, and it just gets incorporated. Having had 3 teenagers, I can understand how that's a tough age group, and I don't have any great advice, I don't think. I try with education, and we try, and for the teenagers that I'm treating, as much as I can, deal directly with the teenagers, encourage them that they're driving their own bus, and to educate them as much as I can and empower them to take leadership in their own healthcare is the best way. But it's tough. It's lousy. There's lousy things about this situation, and wearing the AFOs is one of them. It's less lousier than the surgery, though. I can tell you that. It's way less lousier than the surgery.
Good point. I have another question here. Why is it important to wear foot splints while sitting in a wheelchair if the person is no longer walking?
So that's a great question, and as a spine surgeon, that's really important to me, because having weight on your feet is critical even if you're not walking. So we really think of people in a chair as being built from the ground up, their feet up. So if your feet are on the foot plates, when you go over a bump, your tibia feels that vibration. Your tibia feels load. Your ankle sees the load. And it also keeps your pelvis back into the chair. So I can't show you completely with my computer, but what we don't want is people slouch back in their chair and then their pelvis slides out of the back of the chair. Then they can get pelvic obliquity, they can get scoliosis. So we really think of building people seating from their feet up, and the load through their feet is really critical. So and it plays a role in future deformity. So that's an issue that we're always looking at, and I think is a very important one. So having your feet down, having load placed on your feet is critical for bone health. It also decompresses the main vein that drains your leg, the popliteal vein behind your leg. If your leg is supported just by the end of the chair, that leads to increasing foot swelling. At the end of the day, your feet are purple. It's not as healthy for skin health or the tissue health in your foot. You get chronic swelling in your foot. So I think that's a really important issue. You can probably tell because I've got pressure of speech. I want to get the message out about that do not neglect foot position for when you're in a chair. Really pay attention to that. It's really important piece.
Perfect, thank you. And Dr. Reilly, do you ever do surgeries to correct kyphosis, and under what conditions?
Yes, we do, but it's unusual, especially in Duchenne's muscular dystrophy. And the reason for that is that many of the use of zoledronic acid usually arrests any kyphosis that's progressing. And we usually don't get situations where the kyphosis is interfering with the patient's health so much. So where scoliosis can lead to heart and lung restrictions of function and actually put pressure on the heart and lungs, kyphosis tends not to. It does not decrease chest volume. Those patients can usually breathe very well. Their heart's functioning very well. So I'm not as worried about it from a health point of view for that patient's future health. So it ends up often surgery for kyphosis or a smooth kyphosis ends up being the patient's choice. Are they worried about how that kyphosis looks? Is often the choice. There are some special types of kyphosis that definitely need surgery, but those are rare to see in patients that have muscular dystrophy. But there are some subsets of patients that need surgery for kyphosis, but it's less common.
Thank you so much. And for everyone that you did post questions, and unfortunately we are running out of time. I need to jump on the next session, but Dr. Reilly, if it's okay with you, I will take these questions and then send them in an email to you. And maybe we can post your replies back on Whova for everyone to review on the platform later on today.
You bet, Winnie, that would be great. And I'm so sorry about the time mix-up. I appreciate people missing their lunch to come in. I'd be happy to feedback with any questions or input. And I was really pleased to participate so much. And I'm sorry about the scheduling issue.
Don't be apologizing at all. That was extremely useful, and everyone is writing in here. Thank you so much, Dr. Reilly. So very much appreciated by everyone on the line.
Okay.
So I will send those questions to you via email, awesome. And we'll post them back on Whova later today.
Great. Have a great day.
Thank you so much.
Okay.
Bye-bye.
Bye.